I am Dr. Obot Estienne Antiaba, a professor of pediatrics and neonatology at the University of Calabar Teaching Hospital. And this session, we shall be addressing the subject of the management of hypoxic ischemic encephalopathy. An overview. Hypoxic ischemic encephalopathy is a neonatal emergency that requires timely and appropriate intervention. Globally, the incidence is about 1 to 6 per 1,000 live births. However, the figure is much higher in the developing world. Nigeria has the highest incidence in sub-Saharan Africa at about 25 to 30 per 1,000 live births. An important ingredient in looking in managing children with birth asphyxia is anticipation. The obstetrician and the pediatricians have to anticipate the arrival of a baby who is asphyxiated in order to attend effectively. In order to do this, they need to pay attention to predisposing factors in the mother, in the fetus, during labor. Following the birth of the baby, there's need to, the Abgar score is taken at 1 and 5 minutes. An Abgar of 0 to 3 and 5 minutes usually would denote severe birth asphyxia. Some authors say 0 to 2. 4 to 5 at 5 minutes will mean the child has moderate asphyxia, and less than 7 at 5 minutes will mean mild asphyxia. Usually an Abgar score of 7 and above at 5 minutes means no asphyxia. There is the need for prompt and proper action at the start of the care. We need to clear the mouth first and the nose later, after the mouth, after birth. Subsequent care depends on the presence or absence of birth asphyxia. For the asphyxiated, there's a need to resuscitate. At this point, I don't want to take us through the details of neonatal resuscitation, because I think that is going to be a subject on its own. Following immediate resuscitation in the delivery area, the infant is moved to the neonatal intensive care unit. In the neonatal intensive care unit, support care has to be given. Oxygen, intravenous fluids, usually a dextrose solution to start at about 10% dextrose at 60 mils per kilogram body weight. This is, I'm not talking about the term chart. There's need for glucose estimation to ensure that there's no hypoglycemia or hyperglycemia, as the case may be. Pulse oximetry to ensure that that enough oxygen is delivered. Usually, a saturation of 90% is satisfactory. There's need to ensure adequate circulation. A mean blood pressure of about between 35 and 40 milligrams of mercury is aimed at to ensure that there's enough circulation. Maintain fluid intake and urine output, and a urine output of less than 1 ml per kilogram body weight per hour is oliguria. Incubator care is given where indicated. laboratory investigations are essential in the care of these children. Blood glucose, electrolytes, and urea and creatinine, serum calcium, magnesium, and phosphate, full blood count with platelets, blood culture, arterial blood gases, clotting profile, imaging may be necessary, things like the MRI, EEG, cranial ultrasonography, echocardiography, and ECG were indicated. I want now to pay attention to severe hypoxic ischemic encephalopathy. In doing this, I want us to spend some time looking at the SANAT and SANAT staging of HIE. There's stage 1, stage 2, and 3. 2 and 3 are usually cases that need extensive attention. The parameters are stated: consciousness, muscle tone, musculoskeletal control, posture, stretch reflexes, segmental myoclonus, complex reflexes, sucking, and all that. And then what clearly appears that with regard to consciousness, at stage 1, the newborn is hyper alert. Stage 2, lethargic or obtunded. Stage 3 is stuporous. Muscle tone is normal in stage 1, hypotonia in stage 2, and flaccid in 3. The stretch reflexes may be overactive in 1 and 2, depressed or absent in 3. Complex reflexes, sucking in stage 1 is weak, 2 weak or absent, and 3 is absent. The motor reflex is strong but with a low threshold in 1, and a weak, incomplete with high threshold in 2, maybe absent in 3. The autonomic in 1 is generally sympathetic. Stage 2 is parasympathetic. Stage 3 is both systems are depressed. The events in the pupils, heart rate, bronchial and salivary secretions are all well laid out here. An important feature that I just want us to pay attention to is seizures. In stage 1, there are no seizures. Stage 2, seizures are common and they are focal or multifocal. Stage 3, seizures are uncommon, and these of course, this excludes deceleration. The duration, stage 1 will last for less than 24 hours, 2 days to 14 days, and stage 3 will last hours to weeks. Those that need close attention are stages 2 and 3. This is not to say that we won't give care to stage 1. We do, but they are the least hit. Here we come. Moderate to severe HIE, standard stages 2 and 3. For newborns up to 36 weeks of gestation and above, it is recommended that they receive therapeutic hypothermia within 1 to 6 hours of life and for a duration of 72 hours. The therapeutic hypothermia may involve the entire body, when the entire body is cooled, or it could be the head alone. The aim is to lower body temperature by 3 degrees below the normal. If it is the head alone that is cooled, the temperature should be between 34 and 35 degrees centigrade. And if the whole body, 33 to 34 degrees centigrade, all these temperatures taken either per rectum or through the esophagus. At the end of some 2 hours, rewarming should be done, and the infant should be rewarmed over 6 to 12 hours. I have to state at this point, this form of treatment is not available in poor countries. What are the benefits of therapeutic hypothermia? There is reduction in brain metabolism. There's reduction in apostasis. There's reduction in the excitotoxicity produced by glutamate. There's reduction in free radicals like nitric oxide and lactate. And overall, there's a reduction in mortality and major neurodevelopmental impairments in term and near-term infants. We must not forget that excellent nursing care is imperative for survival and mitigation of neurological and neurodevelopmental anomalies. The care of these children is multidisciplinary. We need the services of the neonatologist, the services of the neurologist, the nurses, the pathologist who will give us information on the changes in the biochemistry and hematological changes. So a lot of disciplines come into the care of these children. For those children who have convulsions, phenobarbital is the first line of treatment for neonatal seizures. And it is given at the loading dose of 20 milligrams per kilogram body weight, administered at the rate of 1 milligram per kilogram body weight per minute, and then 5 milligrams per kilogram body weight thereafter. Phenobarbital is known to prolong and potentiate the action of GABA, gamma aminobutyric acid, which we know is an inhibitory neurotransmitter, and it acts also on the receptors. And higher doses are known to directly activate the receptors of GABA. I take it again. Phenobarbital prolongs and potentiates the action of GABA on its receptors, and higher doses of phenobarbital do activate the receptors. Other agents that could be given are phenytoin at the dose of 20 milligrams per kilogram body weight. This is usually given in refractory seizures. Fesophenytoin, a relative of phenytoin, may be preferred as it is less prone to cause hypotension. Remember that hypotension is not helpful in this case because it will reduce cerebral perfusion. So it is less prone to cause hypertension, and of course, it's known that when it traversates, and then it doesn't cause any harmful effects. Benzodiazepines are also useful in the control of seizures, and are given in the dose of about 0.1 milligram per kilogram body weight. Another agent that can be given is levetiracetam, and this is an agent that has been found useful. While doing all of this, we realize that there may be an organ dysfunction. So there's a need to check out the renal function of this patient. Is there acute kidney injury? Is the child in cardiac failure? The lungs, the respiration of this patient, the blood, is there any bleeding? All these are things that are necessary in ensuring that our care for the infant is complete. So we don't just pay attention to events happening in the brain of the child and lose the child through events elsewhere. There's need to prevent hypertension. Dopamine may be needed when there's hypertension. There's need to correct acid-base balance, hypoglycemia, hypokalemia, and anemia if this occurs, and please treat infection. The impact, the worst impact, as it were, of this condition of HIE is on the brain of the child. You know, we are what we are because of the integrity of the brain that we carry. And neuroprotective agents have become very useful in the care of these children in order to reduce whatever brain injury that will attend this situation. Melatonin is produced by the pineal gland, is known to help recovery from hypoxic ischemic, from hypoxic insult, and it also helps glial growth, and it is anti-apoptotic. Xenon and argon, these are noble gases, and they are known to, xenon is known to inhibit NMDA, you know, that's a receptor for glutamate, and argon also reduces brain cell death, and it is also useful when combined with therapeutic hypothermia. Allopurinol reduces the formation of free radicals by the inhibition of xanthine oxidase pathway. And you know, free radicals are very important agents in causing brain destruction. Magnesium sulfate is also an inhibitor of this receptor for glutamate, that's NMDA, and it is known that to be useful when combined with therapeutic hypothermia. Other agents are azithromycin. This is neuroprotective and is good to combine with cooling. Topiramate is a carbonic anhydrase inhibitor. It is known to block voltage-dependent sodium and calcium. It also inhibits glutamate channels and enhances the action of gamma aminobutyric acid. Monocellular gangliosides. These prevent apostotic death and attenuate brain injury. Here is a chart showing agents that are used at various stages to mitigate brain damage and produce some neuroprotection. Strategies: reducing cerebral metabolic rate, hypothermia would do that. Blocking NMDA receptor channels, magnesium. Reducing the release of glutamate, adenosine agonist, adenosine uptake inhibitors. Inhibiting voltage-sensitive calcium channels, calcium channel blockers are found useful. Reducing free radicals scavengers such as allopurinol, vitamin C, vitamin E, superoxide dismutase are found useful. Preventing the formation of free radicals, agents such as indomethacin, ion chelators, allopurinol, and nitrous oxide inhibitors to reduce inflammatory reactions. Allopurinol, inflammatory antagonists such as agents that block inflammatory, and these are things like steroids, and those that are blocking leukotriene and tumor necrosis factor. Agents that attenuate the apostatic pathway, caspases inhibitors. This is a diagram just to recap very graphically what we've just learned. It begins with acute insult, that's in minutes, bringing about hypoxic ischemic insult, leading to primary energy failure and hypoxic depolarization, reduction of cerebral blood flow, reduced ATP, acidosis, increased excitotoxic neurotransmitters, calcium entry into the cells, and cell death. Learn that there's a phase of reperfusion, and there's next 6 to 15 hours is a latent period of resolution, where there's even also an apostatic cascade, secondary inflammation, and recovery from oxidative stress. The second phase, which comes on in hours to days, results in secondary energy failure. Here we have, there's reperfusion, there's increased cerebral blood flow, but there's reduced ATP, there's increased caspase proteins, there's increased excitotoxic transmitters, cytotoxic edema, microglial activity, increased inflammation, and failing cell metabolism. This could result in cell death. There's a tertiary phase which takes on days, weeks, and years. And here there is myelin deficit, and there's reduced plasticity of the brain and altered brain cells. What we find that there's oligodendrocyte maturation is arrested, there's impaired neurogenesis and axonal growth, and altered synaptogenesis. And these are events taken on a long time after the initial insult. And you can see that there's a window where neuroprotective agents need to be put into use. And the agents that we've mentioned earlier on, they become useful in this window. We go on to emerging therapies. In this, I may mention some of the agents that I mentioned earlier, but they're still not very widely used, especially in resource-strapped regions. Now, emerging therapies, these are neuroprotective agents or strategies to mitigate brain damage during secondary energy failure. They target the pathophysiology by reducing oxidative stress, antagonizing excitatory neurotransmitters or blocking their receptors, anti-inflammatory effects, and immunomodulation, and reducing apoptosis. Amongst these are optimal placental transfusion. This implies delay in cord clamping, allowing more blood to flow from the cord into the baby, and or stripping the cord towards the baby to increase flow of blood into the baby. The baby ends up with more blood in the system. We see how this works. Iron, by this mechanism, iron is acquired, more iron is acquired by the baby. And we know that iron helps in brain myelination. So in the face of the insult, the extra iron obtained could help in mitigating injury to the brain. Other agents that have been found useful, vasopressin. Animal studies show that it is neuroprotective, and it is known to activate the hippocampal interneurons and also suppress synchronous neural activities. These are information from animal studies. We need to see how this works out in humans. The other is erythropoietin. This is produced by the kidneys, and in some instances could be produced by the liver of the fetus. Erythropoietin is a cytokine. It stimulates immune response. It is an antioxidant and anti-inflammatory. It also reduces apoptosis. I know this agent is in use in more advanced settings. There's the remote ischemic post-conditioning, and this is just lethal, sublethal, small ischemic insults removed from the site of injury. And this is known to activate endogenous repair. This is obtained from experimental evidence that sublethal, small ischemic insult removed from the site of the original injury could activate some endogenous repair at the primary site. Next is the endocannabinoids. There's the endocannabinoid system in us. it is endogenous. These are important neuroregulators and could help prevent brain injury. Stem cells. Stem cells, we know, are pluripotential. Here, they can be derived from the umbilical cord. There's an umbilical cord blood cells. These are known to protect against brain injury. Indeed, there are two sites, where stem cells may be obtained, from the umbilical cord and from the bone marrow mesenchyme cells. These stem cells are known to secrete trophic and immunomodulatory factors that are helpful in brain injury. This shows, summarizes to a large extent what we've just said in recent times. We'll begin from air. Air here talks about erythropoietin that's made in the kidneys and promotes the red blood cell production in the marrows, which increase the carriage capacity of oxygen. It helps in neurogenesis. It is an antioxidant. It is an anti-inflammatory, and so it helps in protecting against brain injury. After A, there's a B, and this talks about the blockage of those sites where glutamate is active. And by blocking these sites and preventing the release of in the presynaptic and postsynaptic spaces, there's protection. So it protects against brain injury. Hypothermia is neuroprotective. The cannabinoids and melatonin, they promote repair and are anti-apostotic. Stem cells, we just mentioned, are immunomodulators and protect. Then come allopurinol, which is a xanthine oxidase inhibitor and prevents the release of free radicals, and all end up protecting the brain from further injury. There is a lot of research going on to identify markers of HIE. Cytokines released in acute HIE are being investigated as to finding its early and accurate biomarkers. What cytokines are the early and accurate biomarkers of HIE? Studies have shown that interleukin IL-6 and 16 are high in the cord blood of term newborns with hypoxic ischemic encephalopathy stage 3. Unfortunately, this is not very useful, as this is also produced in infection and hemolysis. So it is not very helpful as a marker. Metabolomic analysis and metabolites. Animal studies have shown that metabolites, namely arachidonic acid, botanic acid, citric acid, fumaric acid, lactic acid, malate, amongst others, in some way correlate with adverse neurodevelopmental outcome. And it is yet to see how this work out in humans. Imaging. Magnetic resonance spectroscopy, MRS. This has greatly improved knowledge on the changes in the brain, in the brain metabolism and evolution of HIE. In the first 6 hours of life, it is found that high levels of phosphocreatine connote good outcome, while high levels of lactate and inorganic phosphate connote poor outcome. These are all findings on magnetic resonance spectroscopy. We have gone through the management of this condition, ranging from head cooling, supportive care. We've gone through agents that have been, we know have been in use for a while, and we have come on to newer agents. And I think as research goes on, we hope to have more information. But in conclusion, I want to bring to our mind that the management of hypoxic ischemic encephalopathy is very demanding in terms of manpower, which is multidisciplinary, in terms of supplies, in terms of infrastructure, in terms of cost and time. And this is especially so in the developing world that accounts for the bulk of the cases and which also have weak health systems. Knowledge on care is expanding globally. New modalities of management are emerging. All these further increase costs, especially for resource-constrained settings. There is wisdom, and the wisdom here is that prevention of birth asphyxia is the panacea. I want to thank you for listening, and I hope we will be able to stimulate some robust discussion. My few references. Thank you very much for listening.